All right, I think we should get started. People are trickling in. So we're continuing our series in controversies in liver disease, and today's speaker is one of our full-time liver fellows, Arpan Patel. He's going to discuss frailty, a hot topic in liver transplantation. So thanks, Arpan.
Thanks, Dr. M. So, like Dr. mentioned, the title of my talk is Frailty Assessments in Patient with Cirrhosis, Ready for Primetime. And so we'll be talking a lot about, the review of the literature and focused on a few authors who have really been changing the field. But I wanted to start most of these, this specific presentation with a case, something maybe we've seen a few cases. So this is a 68-year-old gentleman, Mr. Lee, he's a Korean male who has hepatitis B cirrhosis with encephalopathy and liver cancer, who's referred for liver transplantation. He's had a history of tumors that have been treated, but now has a recurrence. He has well-controlled hepatitis B, diabetes, coronary artery disease. He does have stage 3 chronic kidney disease. Based on his laboratory markers, his MELD sodium is 21. And on exam, he does have some temporal wasting. He does use a cane for balance, and you've observed that he walks slowly to the exam table. So I wanted to kind of just start off the discussion by first asking the audience, is this patient frail?
Sounds like yes.
Sounds like yes.
I'm going to go with yes.
Yes, and I think we also probably want to see the patient too, and we don't have that information in front of us. But I want to ask you, what do you base that comment on? Like, why do you think he's frail? Is there anything about his presentation that made you think that?
Temporal wasting. Needing a cane, walking slowly.
Sarcopenia, functional status related issues. Some people might say some of his comorbidities. And then how does knowing whether he's frail or not affect the next steps you're going to do? I mean, to some degree, we're going to be considering this patient to be listed perhaps for a liver transplant. Does it affect your consideration of listing him for a liver transplant?
Sort of a double-edged thing. Can they survive a transplant?
Sicker than their MELD, so in that respect, they might benefit from timely transplant, but they've got to survive the transplant and be able to recover after the risk.
So I think we're seeing, for these stable outpatients, we have this catch-22, which we see often, which is, are we accelerating someone's chance of getting a transplant, or are we delaying the inevitable frailty that's going to prevent them from getting a transplant? But
so I guess the key question is the frailty stemming from the liver disease? That's the question, right?
So, and we will get back to that. We're going to just turn it over to an inpatient now. This is Ms. Sanchez, who's a Latino 49-year-old woman with NASH cirrhosis, who obviously is decompensated and already listed for a liver transplant, who came in with an SBP, which is spontaneous bacterial peritonitis. She had her course complicated by acute kidney injury, had been getting TAPs instead of diuretics. She's actually been there for the past 2 weeks, and now her infection has been treated. And right now her MELD has gone up in the setting of her infection to 25. You observe her, you see her for the first time. She's bedridden with lower extremity edema. She has very tense ascites, and she gets short of breath when walking with PT. So I'm going to say the same sort of questions to you. It's a very different case, but is this patient frail, and what do you base this on? Is it the same things that you're saying that this patient is frail based on?
I think understanding what their status was prior to this acute episode would be important in deciding frailty or not, because if you had ascites and edema, all of these things acutely happen, you're just sick.
And so a question you have is like, what's the trajectory of frailty, and does that impact outcomes, and does that impact our decision? Because I think one decision you're alluding to is like, is this patient going to be fit for listing for transplant, or are we going to say no, let's hold off listing for transplant?
And there's a difference between being sick and frail. So defining what frailty is versus just being clinically ill is probably an important distinction.
So it's a good segue.
Yeah.
Acute versus
I also really like your cases, because this is it's a much younger patient, but has NASH, so they probably look more robust without sarcopenia. But you also put that they're bedridden as well, right? So I think if you just eyeball them, they probably look okay, less frail maybe than the previous patient. Just maybe you're biased because they're younger,
And
despite their volume overload.
And I think this begs the question that we always think of is like, what actually does frail mean? Can we define it, and how does it affect our decision making? So for this lecture, we're going to talk about in the geriatric literature what frailty means, look at the tools that are typically used in geriatric literature for frailty, specifically talk about frailty in patients with cirrhosis, and then I have the task of sharing with you what my own thoughts based on the literature about how can we actually use this in clinical practice, which I think is the hardest part of accepting frailty. So let's talk a little bit about the literature in frailty just to start. So while there is no consensus definition of frailty, many different opinions stemming from basic science literature to clinical practice have characterized it by this decreased physiologic reserve. And in addition to that, they've defined this as an increased vulnerability to trauma and stressors. Although we would hope that the other hope is that assessments of frailty are associated with poor health outcomes. Otherwise, we wouldn't be measuring them in clinical practice. But obviously, this issue is a lot more complicated. What I just wanted to point out is that frailty is kind of the culmination of a lot of factors and probably absorbing many different processes going on for a patient. So it starts with the risk factors, so the physiologic aging of the cell, patient's genetic susceptibility to illness, comorbidities, the environment. And from these risk factors, we then move on to actual observed changes we can see at the pathophysiologic level in patients, which are things we can measure, like chronic inflammation, metabolic changes, inactivity, and malnutrition. When we observe this in an individual patient, we might see things like sarcopenia and anorexia, and then these all consume the definition of frailty. But why do we think frailty would be helpful to know for clinical practice? Well, in geriatrics, frailty has been used to isolate specific populations that might be at risk of poor health outcomes. So if you take the case of someone who is considered non-frail, who has high reserve, versus someone who's frail, who has low reserve, what happens when they get, let's say, hospitalized for pneumonia? You can see for the patients with a low reserve, for a high reserve, they can go through a hospitalization and bounce back. But clinically, we're really interested in looking at the patients who have low reserve, get hospitalized, and may suffer from a poor health outcome. For instance, that patient with SBP who doesn't make it out of the hospital, suffers from another event in the hospital, then another event. We would want to know what patients are at risk of events like that. But in addition, we want to know are there ways to actually modify frailty in a way that we can get them back to a functional status where we can make a clinically meaningful change. So there are two major types of frailty assessments that have been studied in geriatric literature. This one that I'm presenting to you now is the most common one, called the Freid frailty phenotype. You can see it's a combination of performance-based, which means like objective anthropomorphic measures, and then also self-reported measures. So weakness and gait speed are things we can actually measure, versus weight loss, exhaustion, and physical activity to some degree are reported and they're subjective. And this is usually scored on a scale of 0 to 5. The second category is a Frailty Index, which is something called a disability index. So the way this kind of works is that patients are given a survey and told to identify certain symptoms or functional impairments they have, and basically the number of deficits are divided by the number of items you ask them for. So this is less used in literature, kind of affecting patients with non-cancer chronic illnesses. So we're going to kind of focus on the Freid frailty phenotype for now. So that was just a really quick overview over the types of geriatric measures we use. I'm going to now talk about specific literature that applies to patients with cirrhosis of the liver. I would be remiss in not mentioning probably the biggest cohort of patients that have really moved the field in many ways. This is the frailty cohort from UCSF, ran by Dr. Jennifer Lai. Most of the actual evidence that is used for frailty is based off this cohort, which we will take with a grain of salt. But I wanted to speak to you a little bit about the design of her cohort, just because it's going to be the focus on a lot of the presentation. So starting in 2012, she and UCSF group enlisted outpatients who were listed for liver transplant and patients that did not have severe hepatic encephalopathy, which they defined as a trail test of greater than 120 seconds, which is like, connecting dots. They were all patients with the MELD greater than or equals 12, and every study, she notes that about 97% of patients who met eligibility criteria decided to participate, which is really good enrollment. So what they do for every patient on the time that they're listed for liver transplant, not just eligible, but like evaluated, but actually listed for liver transplant, is that they get a combination of the Freid Frailty Index measured and what's called a short physical performance battery. It's similar to the Freid Frailty Index, but they have just other things that they measure that are more objective, and I'll kind of go into that in the next slide. And then patients are longitudinally followed from enrollment. Pre-transplant, they get these measurements measured every single visit. And then post-transplant, they're followed for 3, 6, and 12 months. So that's quite a lot of data that's collected. The data that they use for analysis is censored if the patients become delisted for reasons other than medical instability, like if they started drinking again, or any other reasons that they might become delisted. So, like I mentioned before, there's different types of measurements we can use, to determine frailty. Whereas gait speed and hand grip strength are used for the Freid Frailty Index. And this short physical performance battery uses balance and chair stand. So this is basically asking patients to put themselves in these positions for 10 seconds, and how many seconds can you hold that position for, and feet together, semi-tandem and full tandem. Chair stands are how long it takes you to sit down and stand up 5 times. Gait speed is just how fast you're walking, measured in meters per second, and hand grip strength is basically using a dynamometer, what sort of strength you can generate just with a few seconds of force, which is usually around 20 to 30 kilograms in most patients. In addition to these performance-based measures, they also looked at self-reported measures like I was discussing. In addition to the physical activity and depression screen, the ADL and IADLs are part of the short performance physical battery. So I wanted to talk about kind of the general demographics of the cohort when they initially compiled data for them. It's very similar to the demographics that are going to be used in the remainder of the study, so I just don't want to keep repeating it. But most of the patients are either 57, in this case it was 60 years, so definitely not reaching the geriatric age for most people. Vast majority are men. About half are non-Hispanic whites. They're MELD. Before the MELD sodium came by, this study was done. So the MELD was about 15, which translates to a MELD sodium of about 17 in most studies. The Child-Pugh was 8. About 20% of patients had HCC, and the follow-up time was about 12 months. Just looking back at the most common diagnoses for these patients, about 40 to 50% of them had hepatitis C. But as the cohort became older and more years of data became collected, NASH became a lot more prevalent and Hep C became less prevalent. So what did they find when looking cross-sectionally at frailty when you assess them at the first time that you're evaluating someone for liver transplant? So they found that 17% of patients based on the Freid Frailty Index are frail. 31% had a SBPP, short performance physical battery test, less than 10, which means that 31 are functionally impaired. 24% had had difficulty with greater than 1 just general activity of daily living, which is like transferring, walking, feeding yourself. And almost half had more than 1 problem with an instrumental activity of daily living. So if you actually take this and apply it to the geriatric population, this actually comes down to the functional status of people who are biologically 80 to 85 years old and community-dwelling adults. And that's a pretty significant finding, I would say, when we're thinking about the fact that we're sending these biologically 80 to 85-year-old adults to liver transplant. It's something we should really worry about. Another finding that they did was looking at basically what's the relationship between frailty and MELD. And this was a really interesting finding where they found that even patients below a MELD of 18 and above a MELD of 18 had high rates of frailty. So, you would think that the MELD, which we use as our way of estimating prognosis in patients, is the end-all be-all when it comes to estimating prognosis. And this was out of patients who died or were delisted, but there were a significantly higher percentage of patients that were captured using the frailty metric rather than the MELD score. So showing that there might be something to the frailty score that's captured that's different than MELD. So reviewing kind of the literature, along with this study, I wanted to just to share some other results. All of these cohorts were prospectively collected data for patients, and with the exception of one that I'll mention. This was a study in 2010 that also looked at outpatient liver transplant candidates, and their frailty metric that they used was a 6-minute walking distance. And they found that the 6-minute walking distance increases were associated with a very significant lower risk of death. Whoops, sorry. A hazard ratio of 0.48. And then looking at the other studies, there was another one looking at outpatient liver transplant candidates looking at gait speed, which is part of the Freid frailty. It found that a 0.1 meter per second decrease in speed was associated with 22% greater hospital days for the patient. These were just all these were all like kind of multivariate regressions. They weren't, they were actually statistically sound when finding these associations. Another study by Punita Tandon in Alberta found that in 300 patients who had a clinical frailty scale assessed, these were just outpatients with cirrhosis, not necessarily listed or evaluated for transplant, 18% were frail, and they had the frailty score was associated with an increased rate of planned hospitalization or death. And then lastly, this was a study done by Elliot Tapper. This was a retrospective study as opposed to the other patients, where they found 734 patients who are hospitalized with diagnosis of cirrhosis, and found that activity of daily living score less than 12 was associated with a much greater 90-day mortality. And now this is pretty compelling evidence that shows that these metrics of frailty are associated with poor health outcomes, which we want to see. You would notice that the problem, of course, is that they're all using different ways of judging frailty. And I think that was, at this point, a limitation of the literature that people called for, is that we need to kind of standardize this process when we think about our patients, because we can't be using all these different tools of assessing frailty if we're measuring different things. The other thing kind of about these studies is that they only measured frailty once and we're making the association based on one measurement. So what happens if we look at multiple measurements over time? And I think this goes to Dr. Bonsal's questions, that it's not about necessarily looking at one point, but looking at the trajectory of illness. So Jennifer Lai did this other study, which, well, basically using the frailty cohort, she has done multiple measurements of frailty during the pre-transplant workup. And what she did was try to look at the change between patients by the first assessment to the last assessment, and looked at changes in specific components of the Frailty Index. And you find that, the gait speed, chair stands, time it takes to do 5 chair stands, and the overall battery of the short physical performance battery were significantly different. She made the comment in one of her presentations that, these sorts of rapid drop-offs in functional status are something you expect out of a geriatric population for years, taking years and years for that to happen. But most of the time that this happened was only a 6.8-month period. So these patients are rapidly deteriorating in her cohort at UCSF. But then the question poses is like, are these changes in trajectory for frailty associated, the actual change in trajectory associated with poor health outcomes? So she did really, in this cohort, they did a really clever analysis. What they did was look at the predicted probability of 3-month mortality in patients. And what they did is they kept the same patient characteristics, a man without cancer with a stable MELD sodium throughout their entire trajectory of illness. And then what they did was just alter their grip strength and looked at what happens to patients 1, 2, and 3 when you alter their grip strength throughout the trajectory of their illness. What they found, and you can see kind of with these, like trajectories here, is that patients who maintained the same grip strength at 30 kilograms did have a small decline, but the slope significantly increased when you made bigger changes to grip strength to 26 kilograms and to 20 kilograms, leaving everything else exactly the same. So the showing that one change in anthropomorphic measurements for frailty can make a big difference in patients' outcomes. So I wanted to just summarize what we've kind of talked about so far, kind of before moving to the next step, which is that frailty is pretty common. It happens in about 1/5 of our patients based on the data that I showed you. And just baseline measures of frailty at one time are associated with pretty significantly poor health outcomes, particularly waitlist mortality or 90-day mortality in one study. And the Tandon study looked at unplanned hospitalization. Another study looked at the number of hospital days just from one frailty assessment. And then from the most recent study I showed you, a change in frailty is associated with increased mortality, and it happens really quickly.
Has anybody looked to see if you try to improve frailty, you improve outcomes? Because to me, like physical conditioning, to get up and down from a chair, could be something that could be, improved upon if somebody had physical therapy, etc.?
So I think the short answer to your question is that no one's looked at it, and I think that is the money question. But I think and I think that's the question moving forward that'll be really important for us to answer for our patients when we prospectively follow them. But there's some other utilities to frailty that I think were important that I'll share with you before getting to that. Yeah.
Has any other group applied for things?
Yeah, so there is a multi-center cohort that I'll talk about, which have looked at a different index which she made. And so I'm just going to kind of walk you through what she's done since this point, which is just kind of early analyses using the Freid Frailty Index, and talk about really frailty assessments for our patients in clinical practice. So I think this is really hard because, what I have to share with you is not only the data about why frailty is important, but also tell you that what you're doing right now is not enough. And I think that's a hard thing for us as clinicians, is kind of changing our practice. But I'll share with you some data that's pretty compelling that might make you think otherwise.
Arpan, can I ask you
Yeah.
a question? Sorry to break your momentum there, but this is a question that's been out there for the last 5 years or so. One thing that's been published in parallel that you haven't mentioned so far, maybe you will, is the concept of sarcopenia and the assessment of that. And as a kind of a layperson going into this, I thought they were one and the same thing. Certainly they're associated, but there's a whole other group of geriatric and now applied to cirrhotic patients, assessments of like psoas muscle diameter, at L2 or whatever, and then which are more easily done retrospectively, as a reflection of that. I don't see that kind of assessment in any of these frailty indices.
So I'll share with you, this is a good segue to this slide. And then I'll share with you actually one study that I didn't put in that was done by Dr. Lai on this topic. So yeah, basically there are so many different assessments we can do, right? All I did was talk about frailty, which is in the middle here, but there are assessments of just the eyeball test, which we do, and basically the purpose of this graph is showing that you can have assessments that go from subjective to incredibly objective, but the more you make them objective, the more you make it more complex to actually apply in clinical practice. So, on one end is the eyeball test and even the Karnofsky performance status, which is actually what we use in transplant patients. We have to report a KPS on all our patients. The problem is that these are, while they're simple, they take 1 or 2 minutes, they're very subjective. And on the other end are assessments that Dr. Im was mentioning of sarcopenia. So one way, sarcopenia is just the loss of muscle that happens in patients with some sort of chronic illness. And there has been a parallel literature that looked at radiographic measurements with either X-ray or MRI, looking at the muscle diameter and seeing if that's associated with clinically significant outcomes. The folks who are kind of the frailty cohort, the folks that kind of do this for a living, really feel that while sarcopenia is an important predictor of itself, it is really hard to measure in our patients and not necessarily as adaptable to clinical practice. Dr. Lai did a study where actually she looked at sarcopenia retrospectively from CTs and MRIs that were collected on patients and found that frailty was a better predictor than sarcopenia in her cohort. That being said, there have been many other studies looking at the effect of sarcopenia on outcomes, which have showed something else. I'm not looking at frailty.
But I think the issue with just looking at frailty is that if you have somebody who's sick, has organ failure, they're just sick and sometimes they just can't get up and they can't move, right? So I think, some of that could be just related to the sickness of the patient, you know what I mean? Because I agree. I think if you have some form of like objective measurement, maybe.
So we'll get into that a little bit. I'll just present you a slide on that. But basically, this is a balance of objectivity and also complexity that people find helpful. So this was an interesting study that it's actually a consensus conference of frailty and transplantation that's looked at like what are people doing right now? Are people even measuring any of this stuff? And what they did was they sent this survey to 41 people who attended this conference. Obviously, people are really into frailty, so take that with a grain of salt. But even out of the most enthusiastic people of this, for about 40% don't ever measure it in clinical practice. And interesting, what I found was that most of the assessments are actually done by a nutritionist for the people that actually do this at transplant centers. So I thought that was interesting, the idea that it doesn't necessarily need to be a physician who's doing these assessments. And then they also polled them about what are the major ones they use, and actually there are a greater percentage of people that use the short physical performance battery, which is more complex than the Freid frailty phenotype. So I thought that was interesting, but just speaks to the fact that even the most interested people in this are not even using it. So what's one way we can think of using frailty in a clinical context? I think this goes back to how we prognosticate patients. And what do we use when we prognosticate patients? Well, we use a combination of just patient components, and then what we really do is process the MELD sodium, Child-Pugh score for our cirrhotic patients, look at objective clinical signs, look at comorbidities, look at renal function, and then really a big portion of this is the eyeball test, right? Like, we are seeing someone who's muscle-wasted, undernourished, and what we do is translate that to our clinical impression and the eyeball test, and we make a global assessment of patients. So this is just like a conceptual framework as to how we think of patients clinically when we make decisions about them. So what Dr. Lai did in 2017, she published this literature kind of addressing one of the questions we mentioned before, which is how do we make this into an index that can be used for all patients? And what she did, and I'm not going to go into the complexities of the statistical methods she did, was that she took her entire cohort, which at this point was about 500 patients, and she found a way to basically make a score that combines three objective measurements for frailty. So she cut everything else out, all of the sort of self-reported parts of the score, and looked at grip, chair stands, and balance. And this was associated with a C statistic of about 0.82 when in an internally validated cohort about predicting outcomes. So, she thought just looking at these three metrics and using a cutoff of 4.5 was a good way of distinguishing frailty in this population. And she found that it only took 90 seconds to do an assessment on patients between the grip, the chair stands, and the balance.
I'm sorry, I thought the outcome is definitely
Weightless mortality. Prediction of weightless mortality. So let's look at her results. So the first question we want to think of is, in this newly developed score, what's the what advantage does the liver frailty index give us compared to MELD sodium alone? So if you take a look at these different categories, what it is that they basically take a MELD score and look at, based on the MELD score, what is your risk of weightless mortality based on the number? So less than 5, 5 to 10, 10%. And out of the 61% of people, 61 individuals that are predicted by MELD sodium to have less than 5% mortality, about 11 of them were reclassified to the correct chance of weightless mortality. Sorry, this was done in patients who actually died or were delisted. So if you take a cohort of people who actually died or were delisted, what we found is that there was a reclassification of 11 out of the 61 based on the frailty score if we combine frailty with the MELD sodium. And they found that, in addition, for people who are estimated to have a weightless mortality of 5 to 10%, there were 16 people who were reclassified using an addition of the liver frailty index, 16 out of 29 using a combination of both indices. So what they did was they created this metric called the net reclassification index, finding that in people who actually ended up dying or delisted, about 16% of them actually had a different outcome than what was initially prognosticated by the MELD sodium score.
Was the reverse done?
So they did that on non-deaths and non-delistings too. But
Right, so did the frailty, if you were to use that, and you say you're predicting a certain percent death, but you didn't get that, so then looking at it the reverse, and how many times would you classify someone as a certain risk of death when they were actually had a lower risk?
So I looked at the people that were, like, what you were saying, like misclassified probably, and maybe classified lower.
Classified them, whereas you'd have a down classification based on actual outcomes.
They said that there weren't anyone who was down classified in their manuscript. But they did apply the same category to people who ended up not dying, who were kept on the list. And what they found that there was only really a net, and this was obviously a larger cohort of people, and there was only a net reclassification of 3%. So when they added both, they said about 20% of people either who are dead or not dead were basically reclassified using a combination of indices rather than MELD sodium alone. That's interesting. So one other kind of vis-a-vis the last study I showed you that she published, she looked at kind of the trajectories of predicted probabilities of death of 4 different people. And what she postulated was that the only thing that she adjusted was the MELD sodium score and the frailty. So for people who have a MELD sodium of 14 and are robust, you don't expect them to have a very high waitlist mortality, which is what we expect. And for people who have a high MELD sodium and are frail, we expect them to have a much higher waitlist mortality, which is this is the predicted probability of death. So those extremes make sense. But what was an interesting finding was that in the same patient, there was about a 9 difference in the MELD sodium, and the only change that was made was whether they were robust or frail, which basically meant that there were people who had a low MELD sodium that were actually had the same predicted probability of waitlist mortality than someone with a much higher MELD score. And what this translates to is something we're all familiar with, which is sicker than MELD, right? There are people who have a low MELD sodium score that might be frail, who actually might have a higher waitlist mortality than we can prognosticate. So I thought this was a really interesting finding, showing that at different MELD sodiums, frailty can actually be a superior way of determining whether there is a higher predicted probability of death. So this kind of addresses one of the questions, I think that was 2 of the questions that were made about, is it the liver disease or is it like the fact that they're frail? And I think this graph illustrates that very well. So this basically was a list of the entire cohort of patients with that in the liver frailty group, which is 536 patients. And if you expected that all of them had frailty just based on the fact that they had liver disease, you wouldn't see such a significant variation in scores of frailty. And the point of doing this is even if in the patients that are frail, the patients that are classified as frail, they have many different frailty indexes. People who are considered robust have lower frailty indexes. So what she was trying to demonstrate with this table was that if we all thought that just from frailty alone was from liver disease, we would expect all of them to cluster, and yet we see all this variety, making the argument that that the liver disease itself isn't what's driving frailty. There's a natural spectrum of illness that we see that has various distributions of patients with frailty. She also thought this was a unique tool to give to patients too. If you have someone who has a frailty index of 5.5, you could say, you're kind of on the upper spectrum of someone who's not doing well, and this can be potentially modified to a lower frailty score. So then the next question is, how does the liver frailty index compare to a subjective clinician assessment? And what they did was that in addition to all the data they had collected in their cohort study, they also, for every patient, collected data on this question, which was asked by 7 of the hepatologists, which is, we're interested in your general impression about your patient's overall health as compared with other patients with underlying liver disease. How would you rate this patient's overall health today? Excellent, good, good, fair, poor, very poor. This isn't just a question that came out of nowhere. This is actually a question that's asked on the National Health Interview Survey, which is a national study that physicians are actually responsible for filling out in these random telephone-based surveys. So they've shown that, so 2 things. They've shown that this question is associated with good predicted probability of death from a physician standpoint, and she had a separate publication showing that this question alone was predictive of outcomes in patients on the waitlist. So the question was, does the liver frailty index improve our ability to predict if we combine liver frailty with the subjective clinician assessment? So what they found was, when you do a multivariate logistic regression, a survival analysis, Cox regression, look at the association of liver frailty index with your risk of dying on the waitlist, liver frailty clearly on itself had a high predicted probability of death very well, even when adjusting for age and even when adjusting for the MELD sodium. The subjective clinician assessment, also independently of age and MELD sodium, had a high chance of basically predicting whether patients had a high waitlist mortality. This is interesting in and of itself, that even beyond the MELD sodium, your subjective clinician assessment has some value in actually predicting waitlist mortality. So then they compared using subjective clinician assessment alone, liver frailty index, and using both together, and they found that the C statistic was greater for using both together, and this difference between using the subjective clinician assessment and using both was statistically significant. So kind of answering the questions like, well, it's not one or the other, but a combination of both that are more helpful than just your assessment alone.
Can you remind me how many times this LFI was applied to patients like right after listing, only once, or multiple times?
So the way they collect the data is that they measure it every time. So they basically made a change after they developed the liver frailty index. Instead of collecting the Freid frailty, now they collected it every single visit for every patient. But this analysis only is looking at it at time of listing. And this question is also only asked at time of, well, the analysis they're doing is just comparing both of them that were done at time of listing, and then looking at the outcomes later on the wait list.
Do you have the study the area under the curve for just the MELD score?
Just the MELD?
Did they compare to that or no?
I think you might have, I just didn't put it. But then based on even just this graph here, you can see like from the multivariate regression, the MELD sodium itself wasn't statistically associated with waitlist mortality when you add subjective clinician assessment and LFI. So I would expect this statistic to be much lower based on that. Which is, I think these are just all interesting to think of. You know, we have the dogma of using MELD sodium. There are other things that can be used to actually predict waitlist mortality. So this is answering another question I was put in, which is by Dr. Patel, which was, are we doing this at other centers? And the answer is yes. And there's just a publication that came out 2 months ago that is now doing prospective evaluations of liver frailty index at 9 different centers. Of course, most of them being at UCSF. You know, 70% of them are still at UCSF. But they're starting to collect this data. And what they were looking at in this study were things that are even more basic. You know, ascites and hepatic encephalopathy, which are components of the Child-Pugh score, which we know are associated with mortality in patients if they have or don't have them. What is the prediction of waitlist mortality in patients who have yes, presence of ascites or presence of encephalopathy compared to just liver frailty index alone? And they're using basically the same outcome, which is waitlist mortality. So I thought this was kind of interesting. So I'll kind of walk you through this. So this is the subhazard ratios of when they actually did the Cox regression. And basically every single step basically is another variable added to the multivariate analysis. So starting from the early steps, if you just put ascites and hepatic encephalopathy and in the regression and looking at waitlist mortality, both are obviously predictive, right? Like people with ascites, people with encephalopathy have an association with higher waitlist mortality than people that don't. When you add frailty to that, the frailty cutoff, neither of these become significant anymore. So frailty itself is a much more value than either ascites or encephalopathy. When you put MELD sodium in initially in this, frailty still is significant and MELD sodium itself is still significant. And then when you put age, albumin, Hispanic race, the only things that are significant are frailty and MELD sodium, but frailty to a much higher extent. There's a subhazard ratio of 1.82 compared to a barely significant 1.04 in patients who have MELD sodium. So showing that, you know, while we think that ascites and hepatic encephalopathy are associated with more mortality, it might just be because we're not capturing the right thing. Just to kind of prove this point home, they stratify patients based on whether they are frail or not, and it was pretty obvious that in whatever category of either as having ascites or not having ascites or having both, patients who are frail were definitely more likely to have waitlist mortality in all categories. So really kind of begging the question is, are we really thinking of the right thing when we're talking about a patient with ascites and encephalopathy? Are we really capturing their waitlist mortality? So the argument that's made by Dr. Lai and her colleagues is that we really should be using another objective measure in addition to the eyeball test, in addition to the MELD sodium and Child-Pugh score when we're making error assessments of patients. And I think the series of studies she's shown to this point have really kind of answered those very specific questions and have done that in a robust fashion. So just to kind of sum up what we've talked about so far, we only have a few minutes left, is that LFI is an independent predictor of waitlist mortality. Separately from the MELD sodium, hepatic encephalopathy, ascites, and a subjective assessment. Combining the liver frailty index with other prognostic measures like the MELD sodium and the subjective assessment are superior to the liver frailty index alone. We shouldn't just use it in isolation. Based on their experience at this transplant center and many other transplant centers in the multi-center cohort, LFI assessments are quick and objective. And now based on the multi-center cohort, we now have internally validated and externally validated data. There are obviously some limitations. You know, this is done in mostly a cohort of patients who are listed for liver transplant. So if anything, it might be actually underestimating the waitlist mortality. There might, you know, our patients that don't even make it to transplant or evaluated for transplant have probably a much higher mortality when they're not under the care of a liver transplant center. So that might not be a limitation, more just like if we're actually maybe underestimating the mortality. What I found interesting is in all these studies, they didn't really make adjustments for comorbidities, and I think that is kind of a missed opportunity. You know, clearly if patients who are on dialysis or patients with poorly controlled diabetes, they have other risk factors. So that wasn't something I saw mentioned in any of the studies, and I think is opportunity for us to kind of examine this data a little bit more. And I think that while they do say that, you know, these LFI assessments are quick and objective, I think you still need to train people to do it. Particularly if you're willing to get it down to 90 seconds per patient. These aren't things that are like immediately implementable. And I think while they are quick and objective, there still is a large amount of resistance that may come with actually adopting this in clinical practice. But this is the website that's used by Dr. Lai and her colleagues. It's pretty easy to use. I haven't done any of these myself because I don't have a dynamometer. But it's basically a average of 3 different assessments of the grip strength, the amount of time to 5 chair stands, and then the amount of seconds out of 10 that you can hold those 3 positions. Then the real question, which what Dr. Banzal was mentioning, is that what do we do with all this information? Like, okay, we know that a patient's frail. We're talking about it in the introduction, which is like, what's the next step? Like, are we going to now make changes to patients, and are those going to lead to clinically significant outcomes? We don't have that data yet. I think that's data that now that I'll kind of jump the gun a little bit, but Dr. Lai just recently received an R01 a few months ago, so she's going to be longitudinally measuring these and also looking for ways of ways to modify frailty score in the pre-transplant and post-transplant setting. So I think there's more to come. But I think it also makes us think that we should, for these patients who are frail, we should really double down on the initiatives that we probably forget most of the time when we think of patients who should get treatment for their sarcopenia or frailty. This is just a conceptual framework made in a recent publication, kind of addressing this idea, which is that, you know, there are exercise interventions like aerobic training, resistance training, balance and strength. There's nutrition. These are thought to increase different physiologic parameters such as cardiopulmonary endurance, muscle mass, and improved balance. And one of the goals for all of these interventions should be reversing frailty, as well as addressing sarcopenia and improving physical fitness. And really, what this is kind of setting the stage for is that we know these patients are frail. What are interventions we could do to kind of reduce the impact of the frailty, and are these actually leading to significant outcomes like waitlist survival and even health-related quality of life and some of the complications from liver disease? Are they reversing from the interventions we're doing? I thought this was just an interesting recent publication that came out, looking at the feasibility of a home-based exercise program, which I think is something we should try to strive for all of our patients with cirrhosis. But it was done on patients at the University of Alabama waiting list, and it was only a feasibility study, so they didn't enroll a ton of people. But they actually found that a 12-week exercise program was feasible. They were able to enroll a good number of people. And they did find that just 12 weeks of aerobic exercise and resistance training led to pretty significant improvements in the short physical performance battery, which 2.5 points out of 20 points is quite a big change. And this, as you recall, is one of the measures that was used in making the liver frailty index. So I think there is hope that some of our even kind of what seem like low budget and probably high impact sort of interventions can lead to a lot of benefits for our patients. So there is more to come than just looking at interventions to improve frailty. Of course, the kind of pie in the sky is seeing whether frailty can actually really make the next step and be used as a tool for allocation. And I don't think we are close to ready for that yet. But there was a publication that just came out in the last year from Dr. Lai, which really followed frailty throughout the course of a patient's pre-transplant and post-transplant course, because I mentioned that this is actually being assessed in patients post-transplant too. And what they found was that pre-transplant, in this larger cohort, about 30% of people at some point are frail, and that this frailty actually increases in the 3-month post-transplant period, and then does decrease while robustness does go up. So which is something we expect for our patients after a transplant. But interestingly, there is some increased problem in the first 3 months that we should just be aware of for our patients. And of course, this cohort was incomplete because not all patients were able to make it to the appointments in the same interval, so that is a limitation of the paper. Yeah.
So does this make you feel like a lot of what is being picked up in the frailty assessment is liver related? Because you were making the case that it wasn't liver related, but this.
I don't think I said it's not liver related. I just think that there's some stuff that's not liver related because clearly
This shows, you're down from 29% to 9. It's a pretty big decrease.
Well, I guess one point is that if we thought it was all liver related, that we would think that the meld sodium itself would also.
No,
correlate.
that would make me think that. That would make me think we need some other way to assess liver.
That's possible too. I would say that most people use meld sodium as a good, sort of measurement of liver function
I
too.
agree, but I'm pointing to this data here that shows that when you get a new liver, you have such a decrease in your frailty score that puts your attention back onto liver as the driver of what you were perceiving as frailty, in which case you might want to think about other metrics that you could use to assess liver pre-transplant.
No, and I think that's
actually pretty quick.
Yeah.
Right after 6 months, like 31 to 50.
the only thing I would say is that people who died. So obviously people who died didn't have the assessments. But I would say that this doesn't capture all the people who may have been off. So just this frailty index this in and of itself doesn't necessarily capture everyone per se. But yeah, it does speak to the point, and that's why I think we need more information post-transplant. To what degree is this going to tell us that narrative, which is that a lot of the frailty is from liver disease versus not? I think there is more data to come based on studies like this. I thought it was interesting that they did just a prelim analysis, and this is not a multivariate regression by any means, it's just a t-test. So they did find that if we look at patients who actually became frail after transplant or continued to become frail after transplant, there was a slightly higher length of stay of their transplant-related hospitalization. The 3-month number of hospital days at the 3-month period was also significant, but death wasn't actually significant. So there wasn't a death with frailty with death. But this was too small of a cohort, I would say, to make that necessarily say that association exists just based on a t-test. But I think once they do enroll more patients in this study and get more assessments that are longitudinal, we'll have a better idea. And I think this is really important work, I guess I would just say, because I think we really know and we see that patients in the post-transplant period could also be very vulnerable to stressors. And it's probably important for us to identify those people and then use that data to see what happened in their pre-transplant course that makes them at risk of these stressors. So I'll just summarize the key points, which is that frailty is common, associated poor health outcomes in our patients with cirrhosis. I think we are making the argument from these studies that it can be incorporated in our clinical practice and can really help with prognostication and maybe can signal changes in our medical management. Of course, we still have to show the literature showing that change in our medical management will lead to clinically significant outcomes. And I think the studies that in the kind of last piece that are showing that frailty can predict post-transplant outcomes are ongoing, and it'll be really interesting to see how that plays out for utility in the allocation realm in the future. Thank you.
Questions?
In the studies that you reviewed, were there any differences in frailty in patients with HCC and without HCC?
So the only 20% of the cohort at HCC, they found the HCC cohort less frail. Yeah, less frail. In the multi-center cohort study that was done, they did stratify patients based on HCC status, and I think it's because a lot of people are not cirrhotic. So they included all people. Yeah, going back to it, but they did find that they were less frail. Yeah.
Great presentation. That was really awesome. I was going to say back that slide we went over kind of the different frailty assessments and how on a timeline or on a scale of objective to subjective and conflict and ease of use.
Mm-hmm.
Sarcopenia to Gene's point, something that we've talked about. I was just thinking about the hard part with this would be implementing it, right?
Yeah.
Training people to do it. The sarcopenia, are there any sarcopenia measurements that we can for very logical assessment, maybe missing a lot of the skeletal muscles, but abdominal imaging standpoint, because everyone's getting cross-sectional imaging, right? if radiologists can put in like a sarcopenia measurement, if that's even more objective, like is there any data to show that that may be an easy way to implement a lot of this?
Yeah.
Like,
So
theory?
they have. So I think that's a good question. I think the problem is that sarcopenia, while itself is complex and objective, and it probably is associated with outcomes, it still doesn't tell us a lot about function. We do assume that, obviously people with higher muscle mass probably have more function, but I think it's a good point. What's at least panned out from the literature so far, though, is that all of these have been retrospective. No one's prospectively collected the data and seen that association pan out. The study that Dr. Lai did, like comparing the sarcopenia to frailty assessments, found the frailty was more predictive than the sarcopenia assessments she did. So I guess I think there are just two camps of people who think that, and obviously people kind of want to establish their careers on different metrics, and I do think that people can make the argument of one versus the other.
No, I just wanted to say it would be nice to know if there is like a score that you can just say, we can't transplant this patient, or you know what I mean?
Yeah.
This is very.
I think until we find the association with like if we find that someone is frail and they're not going to do well after the transplant, I think that's kind of a sign, right? Like that will show us if they have a poor post-transplant course, then there is some utility in changing the score pre-transplant.
Yeah, so that's one of the questions I was going to bring up, which is I think that there's some utility sort of in the lower MELD patients where you have a little bit of time perhaps to make some changes to their frailty, because they're not going to get transplanted anytime soon. But I think when the more acute situation is the patients who are sick in the hospital and the eyeball test is being applied because you have an offer, right? That's a scenario where the selection bias is going to be a problem, because what percentage of these patients who were listed who just didn't get a transplant, you're not assessing their post-transplant outcomes with the maybe highest, level of frailty, right?
And these were not, none of these assessments were in hospitalized patients. So I think it still doesn't answer that question of someone who's acutely hospitalized, knowing whether the frailty associated with that is necessarily the same thing as someone who's frail comes into the outpatient.
Right, so that's why I think, adding that to like a MELD sodium frailty is probably going to be, like I said, far away, because you still have not answered that area.
I'm curious about whether the data were analyzed to see if it made a difference if you were sort of bad on all, like you were slow to get up, you had poor balance, and you had poor grip strength, or like, but what if you like were really good in one and like really bad, and did they check into the pattern of the scores, or
they all seem to follow the same direction, and at least from the trajectory, they all kind of fell or went in one direction. So I would say they did, but these scores have been validated in geriatric populations. Of course, that doesn't mean that they're like good in all populations, but I think that they've all kind of, the tabulation of the scores have been associated with health outcomes.
No, I know they have, but
tabulated though, right?
that's not really the question. I understand if you aggregate them, then you get this outcome that you present. But my question is, if you look at them individually and you look at the heterogeneity in the score, because obviously the score is not perfect, do you find that people who have one really bad score and two kind of middle, are they different than people who have three scores?
Yeah, they might be. I mean, I not based on these studies, but yeah, they might be. The studies I showed you here, they did look at some individual scores like gait speed and 6-minute walk distance and found an association, but looking at the relative impact of the other kind of measurements on them was probably something that's pretty useful to do.
In the calculation, is there a difference in the weight?
Yeah,
No, they're all this. There are weighted differences in the LFI. They are different for LFI. I don't know if we can necessarily tell just by looking at the numbers how they're weighted differently, but it looks like maybe. But I think that's based on the numbers more than anything. I don't think they're weighted any differently. It's just that like these numbers just have different coefficients and So I don't think we can tell just by looking at this. Actually, it's a good question.
Well, it's very hard to disconnect sarcopenia from pain. I can't imagine a pain person not with sarcopenia. That's my biggest problem. I think they're measuring somewhat the same thing, even though we have different names for it. I think muscle wasting is
Combine them.
really.
Combine them.
I mean, that's what they should do. I mean, I think it's,
Like, what additional benefit do you get by adding sarcopenia if there's the ability to calculate on a CT scan that they're going for anyway? Like, if there's a significant benefit, then maybe
Yeah.
an objective and a more semi-subjective score put together, and it's a hybrid. And then you could weight the variables depending on their impact.
I mean, you know, at least in the practice, if they take a long time to get off the examining table, that itself tells you they're afraid. So for us, we have all these sort of, you know, little clues.
Eyeball
Tell us
tests.
that,
Yeah.
How long does it take to get off the table, get off the table?
I think for the sake of time, I'll have to end here. But great talk.
Thanks.